The case is 60-year-old female with 30 millimeter gastric asymmetry at mid-body lesser curvature. The patient was scheduled for US FNA. I will give the floor to Dr. Ryouzawa, please.
The lesion is located in the middle body lesser curvature. Now you can see the endoscopic image here, and I change to the US image. Now you can see the US image here, and it is from the fourth layer. I mean the muscle layer here.
This is the submucosa going over it, and then this is the muscle layer here. So it is an expansion of the muscle layer.
Yes.
This is what I call the transition zone. So a very, very good demonstration between normal gastric wall and the lesion itself. So a very good demonstration.
And the lesion is not look like the typical submucosal tumor. It is not round shaped, and the margin is very unclear, irregular, and the intrinsic echo is heterogeneous.
Yes.
Dr. Ryouzawa,
Yes.
Ryouzawa sensei,
Yes.
can you show us the endoscopic image again, please?
Yes.
Here.
Please, can you show us the conventional? Yes.
Yes.
Thank you.
It is pull back, I think.
Yes. Yes.
Oh no. Okay.
Like this.
So it is not so. It is not so endophytic. It is more, we say, sort of exophytic. Not so impressive on endoscopy, huh? But that is the lesion there, right in the middle of the field. Okay.
Okay. So back to
Thank
the
you very
US
much.
image. Oh, okay.
Yes.
Yes, thank you very much.
And this is a US image.
So again, I think that what impresses us, as Dr. Ryouzawa showed, is it seems to be inhomogeneous. There are some darker areas and lighter areas, and then the outer border normally is very, very, very smooth, but the outer border is not so clear. So these are two worrisome features
Yes.
that make us think a more advanced lesion. And then we
So, Dr. Ryouzawa and
Yes.
Rob, so what is the potential diagnosis in this case?
I think it's
If
not
you
the
worry about
not submucosal tumor, but some malignancy.
I think
so not typical of a GIST.
No, I don't think so. How do you
Yes.
think about?
so. I think if it is a gist, it's got some worrisome features to it, Philip. Again, the irregularity and the inhomogeneity make us wonder about the exact nature, but it is not a typical, as you know, stromal tumors in the stomach are usually
Yes.
GISTs, not leiomyomas, but this one looks to me to be more worrisome. So I think our options are to, and Philip, maybe you can weigh in on it. One option is to do FNA, to better characterize it, understand exactly what it is.
Yes.
The other would be to just say, look, it's worrisome, and maybe we should go straight to surgery.
I think we need the histological evidence and After that, we can choose the therapy.
The best
I think.
therapy.
Yeah.
Do you agree, Philip? Or would you want to take this patient to surgery
Yeah.
right away?
No, in this location, is it more to the lesser curvature side of the stomach?
Yes.
Yes. So
Yeah,
it's sort of
so,
posterior wall,
a
lesser
ordinary
curve.
Yeah, so an ordinary wedge resection may be sometimes more difficult in the laparoscopic approach. So
Yes.
if the histology confirmed it's a kind of different pathology, we may plan the surgical approach in a different way. Typically, GIST, we can do it by wedge resection, but this may not be. So I think it's good indication for histology. How about contrast EUS? Will that help, or you think there's no need for that?
I don't think it is helpful.
I think it's a
I see.
very, very interesting question. You know, we have now, Philip, some sort of more advanced imaging, what we say adjunctive modalities to EUS. We now have with the EUME2, we have elastography. We also have the possibility for contrast agents. And I think they are of a help in maybe improving the chances of making a specific diagnosis. But in my view right now, they are not a substitute for tissue. So if you really need to know specifically what this is, to my view, you still need tissue, I think.
Yes.
Okay.
So
So you're going to use Olympus needle?
yes, yes.
Okay. Is this a side port or only end?
Without side port.
Without side port.
Without.
Okay.
Okay.
So we have a 22 gauge needle from Olympus. No side port. This new needle design, the handle, better actuation, adjustable for the sheath. So we adjust now to bring the sheath out.
Yes.
Dr. Ryouzawa, excuse
Yes.
me, may I ask a question?
Yes.
Why did you choose a needle without a side port for this case?
Personally, I don't think the side hole is useful to get more specimens. This is my personal opinion.
In my opinion, the data is not robust enough for the side port to show that it makes a difference. Maybe it does, but we need more data.
Yes. Okay, so
Okay.
I will pack it.
So we pull the stylet back just a little bit. Here is the needle coming out. He adjusts the needle with the elevator, and now we are clearly in the lesion now. And you can see he likes to adjust the depth. And now make, we say staccato. I don't know in Japanese, but quick movements.
Yes.
Not slow movements, but quick movements in order to overcome the resistance. So staccato movements. So now we will put suction,
Yes.
and you will use the fanning technique. I hope.
I try.
Okay, so withdraw, and then a fast puncture in. So adjust the scope, fast puncture in. So you should go from each end of the lesion to the other. So between my hands, you should go all the way. Not the longer the distance, the better the specimen, I think. And now he changes the trajectory. So if this is the lesion, we try to get many trajectories through the lesion. Not just one, but many.
I sometimes use the large foil and elevator.
So the way you adjust the trajectory is you can adjust with the elevator or with the up-down.
Yes.
May I ask a question?
Of course.
So how many times do you usually puncture to get appropriate samples?
Usually around 20 times.
20
So
times.
usually I will make 4 passes with each trajectory. So back and forth 4 times, change the trajectory back and forth 4 times until I've gone from one side of the
Yes.
lesion to the other. So,
Thank you very much.
Okay.
okay. Oh, okay, do we have a camera to show the specimen or no?
映してもらっていいですかね。
Impossible, I think.
無理。うん。じゃあ、カメラある？ありますね。はい。
Ah, yeah, okay. I think it was fairly soft. The lesion was fairly
Yes, yes,
soft.
yes.
Agree?
Yes. ありますね。
So now this will go into cytolite, or will you make some slides to look at?
Yes,
or-
yes.
Okay.
There is a pathologist.
Ah, okay. So we will make slides, but also to put for cell block, I think, as well. Okay. And on the second pass, will you use the stylet again or no stylet?
Usually I use stylet
You
again.
use stylet, okay. So this is a difference in our practices. So I use a stylet for the first pass, but we feel the balance of studies suggests the stylet is not helpful. So to increase efficiency, my own practice is to not use the stylet after the first one.
I see. The specimen we take, and we just can say that some cell component is acquired. And because today the pathologist is not in this hospital, so tomorrow we provide the cytology and the histology for the pathological examination. So maybe we can show you the result tomorrow. Okay?
So do you think this is a good yield?
Sorry?
Do you think the cell is enough for the pathology to have examination?
I think so. As you can see, there is not the stromal cells. I mean, not spindle cells, but epithelial component, cell components.
Well, thank you very much for the beautiful specimen.